So torticollis is a condition I commonly see in the pediatric setting. This is a condition where a child may have a crooked head, or their alignment is a little off-kilter, so they're side bent in one direction and typically rotated contralaterally. However, that's not always the case. That's only if one sternocleidomastoid is affected and if it's both branches. Sometimes we can have a positional fault to where they are looking down in one direction and they're rotating in the same direction. So you have ipsilateral rotation and side bend, kind of like this. So one head of one SCM is affected while the other head of the other SCM is affected. So there are multiple types of torticollis that I personally see in my setting. Primarily with younger infants, we're going to look for the congenital muscular torticollis, the postural torticollis, and the ocular torticollis cases. There are others, but they're either a little less common. I see them in more of the adult population, or perhaps they're more red flagged or referred out. For example, like neurogenic and osseous torticollis are probably not something I'm going to treat myself. Neurogenic because of all the red flags associated with that condition, and perhaps it's a spinal cord tumor or something else as ominous. In osseous, if there are abnormalities of the bony structures, no amount of stretching, strengthening, and so forth is going to really change that. So again, that's more of a surgical corrective procedure or refer out. In regards to torticollis induced as a result of infection, sometimes this can lead to bony changes, but sometimes the infection is a simple ear infection, and it's just enough to where it causes a vestibular dysfunction, and for the week, 2 weeks, they have that ear infection. They have this temporary, situationally induced torticollis that subsides on its own. And then in regards to scoliosis cases, it's not really its own torticollis, but I typically devote a whole thing just to cases where a child who has scoliosis may go ahead and develop a torticollis in compensation to match their visual field to a more appropriate input. So going back to the three primaries that I personally see and treat, congenital muscular torticollis is primarily seen in children who are very, very young. So less than 2 months of age is ideally when they've received their diagnosis. And this is as a result of perhaps birthing trauma or positional alteration in utero. I see this commonly, especially with larger twins. Typically twins come out smaller, but if they are larger and there's less room in that uterus, then sometimes one twin will have one directional preference and the other will have another, depending on whether they're in a koi fish position or not. For postural torticollis, this is induced via the container or apparatus a baby spends most of their time. So that old saying, container baby, applies for postural torticollis. So perhaps a child sits in their car seat all day and they kind of acquire this positioning. Well, in this positioning, I have a rotation to one direction and a side bend to that ipsilateral direction. So here's an example of when it might induce two different heads of both SCMs rather than a singular head or a singular SCM with both heads implicated. So that's why it's quite important to recognize when we get to the treatment componentry that it's not, this is what I do every time for a left torticollis versus a right, because we as PTs typically say a torticollis is dictated based on the side bending preference, and that causes a lot of confusion because sometimes that sidebend is associated with ipsilateral, sometimes a contralateral rotation. So normally, whichever side that child is primarily directed is what I use in my own practice as far as what I call the torticollis itself. But that's beside the point. Now, why is it important that we address torticollis? Why do we really focus on it so heavily in physical therapy? And the reason is, as an infant grows and develops, their head shaping is not fully solidified because the ossification of their sutures and their fontanelles haven't fully solidified. So you can have very prominent brachycephaly and plagiocephaly that develops pretty quickly in cases where there's torticollis. And so if I'm perhaps in this position, the posterior lateral on the left side of my head might be a little bit more flat for prolonged supine positioning if I spend every day supine. So having the potential conversation with mother, father, guardian, you name it, in regards to potentially acquiring or seeking a plagiocephaly helmet might be quite influential. In regards to discussions on scoliosis, sometimes scoliosis causes the torticollis, as I discussed earlier, but sometimes a torticollis might be enough to induce a scoliosis, because if I'm locked in this position and my visual field is slanted, I may want to side bend my trunk, and now everything is level from a visual standpoint. So sometimes it's easy to tell which came first, sometimes it's challenging, but another reason for why torticollis is an implicating factor for a child's normal growth and development is as a result of acquired hemi-neglect from prolonged positional faults. So if I'm locked into this position, frequently looking to my right, I will tend to give the right side of my body, so my right arm and my right leg, a little more opportunity for growth. And what that's going to do is promote an asymmetry from my right to left side of the body. So you may see skill acquisition far more advanced on my right side versus my left. My fine motor, gross motor skills might be very solid on the right, poor on the left. That can lead to balance impairments as well. And of course, balance impairments are going to be present if this torticollis is vestibularly linked. Like a lot of our premature or micro preemies would be, typically they're hypotonic, they've got vestibular dysfunction, sometimes ocular dysfunction as well, and torticollis is really easy to go ahead and set in. Now, moving on to the actual treatments. So typically in PT, the things we do are stretching, strengthening, active range of motion, sometimes a little soft tissue work. In this, it is very influential, yes, but I would argue that parent education is perhaps just as important, if not more important, because what you do is an hour, maybe 2 hours a week with the child, but parent education is for the other countless hours of the week. So the things I preface my initial evaluation with, even before I start treatment, I will go ahead and ask the parent about the history of the child, if there's any infection or so forth. But once I've established this child has torticollis, I want to bring to light the easy modifications a parent can make in their day-to-day routine or the layout in their room to facilitate a more normalized positioning of that child's head. So, for example, it can be as easy as this child has a right rotation, and in their crib, they always look to the right because the door, the people, everything exciting is on this side of the world, and on this side of the wall, the crib is against the wall. So the baby has no incentive to look to the contralateral direction. So in these cases, I may just have mom go ahead and 180-degree shift baby, and now baby is looking at a solid blank wall. This is really boring. I want to go ahead and look contralaterally. Now, if the child is on a lot of equipment and perhaps the equipment has wheels, they're in a non-opportune bedding apparatus, maybe it's a hospital bed that only reclines on one side and you can't exactly flip them 180. Go ahead and recommend rearranging the room to where the child is perhaps on another wall or another part of the room to where most of the commotion is away from the side they're currently rotated. Again, incentivizing them to look to the other direction. Another thing I might go ahead and do is educate the parents on positions of the TV in the room. A lot of kids gravitate really quickly to TV, iPads, phones because of the bright lights, the loud noise, the music that comes from it. So if that's in a room, sometimes I will have the child positioned to where, again, that is the enticing factor to rotate contralaterally. Now I'm not recommending extended TV time or anything for a child, but if a TV happens to be in the room, you can use that sometimes as a stimulus to induce contralateral rotation. Moving on to other pieces of education, bolstering is highly impactful, especially for those postural torticollises where a baby's sitting in the same container all day. Go ahead and put a very firm rolled towel bolster to prevent or block that child from going into that same pattern of side bending or rotation, whichever you're trying to prevent. I do not like soft, squishy, furry things because a child has a little bit more of a suffocation risk for occluding their airway. So I try to keep it relatively firm, and especially when the child is being introduced to a bolster, I like to have parents supervise it at all times, just as a liability thing. Now in regards to breastfeeding, this is a really important topic to touch up on, especially with first-time mothers or mothers who didn't take perhaps a birthing class, and they are only familiar with the classic cradle technique where mother holds one breast and child looks like this. Now, you can do a cross cradle technique where mother holds one breast and baby goes here. You can do the opposite breast and baby is held here in a football hold technique. But keep in mind that the three I just demonstrated, one like this, two like this, and three like this, all induce the same directional orientation. In this case, this is the child's right rotation. So this is impactful because most mothers subconsciously have a dominant arm and a preferred nipple. So in this case, what you'll actually want to recommend is another 180 degree, and perhaps that might mean switching breasts. But in this, now baby has a preference for right, but we are engaging baby in a task that he or she really loves, eating. Most babies are infatuated with it. So in this position, now you can induce a right, or in this baby's case, sorry, a left rotation, and you can do those same techniques. One of the things that I think are important to make note of is sometimes mother, especially if this is a very newborn infant, mom had a complicated pregnancy and it was removed via C-section, she may still have abdominal scarring. So if she wasn't educated in the hospital on the football carry technique, This one does not apply any pressure to the abdominal scarring here. So that might be a more preferred route. You could also do the side lying technique. Go ahead and just Google that if you want, if you're not already familiar, but that's another option. But that is a way you can induce contralateral rotation for a child who has torticollis. Now that covers the educational piece for the big highlights that I prefer to implement. I did forget to mention, if I'm feeling a pseudotumor, as in some cases with congenital muscular torticollis, I think it's like 1 in every 3 per the literature, but that, if you identify it, I normally refer out just in case it is not just a pseudotumor, but a full-blown tumor or some other condition that I just want to have a second set of eyes on it. So that it might also be something I educate the parents on, but I'll find that in the palpation screening and so forth. Now, moving on to stretches, strengthening, active range of motion, and soft tissue work. Low-hanging fruit first, soft tissue work. So let's say a child has a raised shoulder and there's a lot of increased density to the upper trap on the right. The paraspinals also have increased density throughout there. Note how I'm not saying hypertonicity. Too often we as PTs inappropriately use hypertonicity in relationship to increased density. Remember that hypertonicity is a resistance through a passive range of motion that is velocity dependent. I'm literally just referring to, I push on the texture of the skin and it's more dense than usual. So I'll go ahead and calm that tissue down by doing some soft tissue work on the upper trap and the paraspinals. I might even do the parascapulars. I might go into the cervical spine, but after I do that, then I do stretching, strengthening, active range of motion, and then I end with, again, soft tissue work. And each time, soft tissue only lasts a couple minutes. It's nothing super extensive. It's just to settle the muscles and then get into the meat and potatoes. So for stretching, it's quite simplistic. I try to replicate positions that a child either already is exposed to or is happy in. Our normal formalized or formal testing procedures are where we lay the child on their back and then we rotate left, rotate right, side bend left, side bend right. I find this quite inappropriate with infants and just younger children in general because they're very upset. No child really likes you to hold their head and move it in fashions that they're uncomfortable with. However, mothers and children love to be held. Mothers love to hold their children and children love to be held. So one of the techniques I personally use is just a nice hugging technique. And in this fashion, what I'm doing is I have a normal hold on child. And from here, I'll go ahead and bring my top hand up and I will rotate the child's head to the side that I want to have stretched. You'll notice though, here if I bend over, there's a lot of distance between my chest and the shoulder. In this case, what I'll have to do is use my thumb to pull gently and press the shoulder into my chest. So you can do that in one smooth motion, coupling the two, or you can do it one at a time. It's entirely personal preference and the child's preference, but I really like this one for a stretch into rotation. For a stretch into side bending, what we will do is a similar technique or a style, but this time we're going to side bend or put them on their side. From here, I've got these two fingers trying to stabilize. If I lift this head up, this shoulder stays put. So here, what I can do is hold the child like this, and I use my elbow to side bend the head. And this is the side I'm stretching facing the ground, and the whole time I'm maintaining, again, shoulder fixation here to accentuate the cervical side bend. If the child is side bent and rotated in one direction, we will go ahead and compensate, and our stretch is then going to be up and forward, and that's going to stretch the true side benders. If we go straight up, we're going to stretch the anterolateral musculature more than the true lateral musculature. So it's important to keep that in mind. Now let's say the child is side bent this direction to the right and rotated to the left. If I were to just do a full stretch into side bend here now, what I'm stretching is more so the posterior lateral structures on the right side. So when I'm doing this, what I want to do is, as I lift my elbow up, I'm going to kind of nudge the child into my chest a little bit more. It looks kind of like you're going to be obstructing the child's airway and suffocating them, but if you actually look from an aerial perspective, there's plenty of space. They might get a little aggravated that you're covering their eyesight occasionally, but normally you're okay with that. So those are the stretches that I find most agreeable with children and less scary for parents, because sometimes parents, especially if they're first-time parents, a stretch like this is quite scary. They might think you're gonna break the child's neck. They might think they will break the child's neck when they perform that, but they are much more comfortable doing a hug or holding a child on their side. So how are we going to strengthen these muscles? So let's say the child is side bent to the right again, and I want to strengthen the contralateral or the left side. So what I will do is, very similarly to how I stretched, I will have them in that same position, and I will hold the child and support their head. I'm going to lift their head up, almost like I'm going to stretch the opposite side, but I'm just lifting slightly up so I can drop. When I drop, a child's natural response is to keep their head floating in space, not to let it just completely fall to the ground. So what they do is they maintain this position, and I'm holding the child's head just to demonstrate with this finger, but normally this finger would not be there. But now the child is in this position, strengthening this set of side benders. So that's literally all I do for strengthening, and it works very, very well. If we have a child who is now side bent and rotated, in this case, the side bend and the rotation are in the same direction, and I have my thumb on the chin just to maintain position. Normally I would not do this to an actual child, my hand would still be here. But for the purposes of this demonstration, this child is rotated here. If I bring them to fight gravity in this position, the structures facing the ceiling are the ones that are primarily going to be strengthened. So in this position, a right rotation with a right side bend floating in space like this activates the posterior lateral structures of the neck. So what I need to do to accentuate the true side benders is, if I'm here, I need to lean back. So if I sit in a recliner or slouch against the wall while sitting on the floor, I now accentuate gravity pushing down on the head in activation of the true side benders. Now let's say child is side bent to the right again, but this time rotated left. When they are floating in space in this position here, and again, I'm holding the baby doll's face so it doesn't just go back to neutral, but you would hold down here. In this position, side bent to the right, rotated left. In this position, it's the anterolateral structures that are being strengthened. So if I want to move posteriorly, anatomically speaking, I need to actually lean forward. And now the structures facing the ceiling are going to be the true side benders. So here I can maximally strengthen the child in side bending. So those are the modifications I make based on rotary componentry coupled with side bending. So stretching, strengthening, now active range of motion. This is quite important to follow up with. Let's say this child is an infant. They don't sit up yet. They are not quite comfortable with full-on tummy time unmodified yet. You can rest them on your chest and you can sit in a recliner. By doing so, this is a lot easier for them to fight gravity and they can lift their head up. From here, I can play with a rattle, or I can play with bubbles or beads, and I can draw their attention to their non-preferred side. I can then have them track to the other side, but I want to accentuate the side that is against their current directional preference. Now let's say the child is comfortable with a modified tummy time. Then I'll do the same thing in a full-on tummy time, going left, going right. Let's say this child wants more exposure to rotate, or you want to give the child more exposure. You can also do it in supine, going left and going right and so forth. If you want to advance it further though, that's when we go to sitting. Sitting for visual tracking is a bit harder than it is for supine. So you may notice a little bit more when it comes to saccades, if it's a newborn, in this position versus a supine position. In regards to a child visually tracking, we're still doing left, we're still doing right. You can do the same activities there too. Other than that, those are the main take-homes for the different types of torticollis, why it's important to address them, the methods that I use to address them in my particular practice. Hopefully you found this helpful. If I left anything out, I'll probably do a follow-up or something of that nature. All right.